then discuss the characteristics of pneumococcus. Those ones you will cover, or you should have covered in details in mycology, or virology, or bacteriology. Okay. So respiratory tract infections are both upper and lower. Both upper and lower. Okay. So this is for upper nasal cavity, pharynx, larynx. So we'll have pharyngitis, rhinitis, and even laryngitis. And then now on the lower, we have laryngobronchitis, we have bronchitis, we have bronchiolitis, and then now you have the lung parenchyma giving us the pneumonias. This is how normal alveolar looks like. We have you have the type 1 pneumocyte. This is the one that's involved in the respiratory pathway. And then you have the type 2 pneumocyte. This is the one that makes surfactants. And here is normally what we call a respiratory membrane. We are saying oxygen has to pass from here and get into the blood. So most of the symptoms you'll have, whether for respiratory symptoms, either there's a problem with this membrane here, there's a problem with the type 2 pneumocyte, or the whole alveolar is packed with something else that's not air. This is how a normal alveolar looks like. It's normally just space. It has this thin lining consisting of the endothelium and the respiratory membrane. You can see these ones are empty. These are normal. And there's nothing in between. For the upper respiratory tract infections, these are basically infections of the airways above the glottis of the vocal cord. So we'll have tonsillitis, pharyngitis, laryngitis, sinusitis, otitis media, and rhinitis. And basically, if the patient has cough, a sore throat, running nose, nasal congestion, headaches, typically low-grade fever, the facial pressure tends to be from the sinuses, and sometimes they sneeze. As I said, usually not severe infections, more so just bothersome infections. And most of them are caused by viruses. Rhinovirus, coronavirus, adenovirus, influenza virus, parainfluenza viruses, human metapneumovirus, and respiratory syncytial virus. For the rhinitis and the common cold, these are the common ones. Of course, rhinovirus tends to be the most predominant viruses that cause rhinitis or common cold. Remember, there are other causes of sinusitis that are non-infectious. There are allergic sinusitis. What we are mentioning here are infectious sinusitis. That's infections of the sinuses, frontal headache, facial pain, nasal mucus, the nose appears blocked. And the agents of the acute sinusitis, most commonly, again, viruses, rhinoviruses, influenza viruses, and parainfluenza viruses. And of the bacteria, we have a staph pneumo, we have Haemophilus influenza, and then we have a Moraxella catarrhalis. And for the hospital-acquired or patients who are sick or in a hospital setting, what we call nosocomial. In nosocomial now, you have other Pseudomonas and gram-negative bacilli. These are Enterobacteriaceae. I'm really hoping you have done some microbiology. Wait, have you done microbiology?
Yes, we have done.
Okay, good. Then it will make my life very easy. Now, For the chronic sinusitis, you can get obligate anaerobes, or you can get staff. Staff can do that, but again, this will be in a context of a patient who is immunosuppressed or have some uh, uh, like a device input or intubations or something like that. The most common cause of the infectious sinusitis tends to be viruses. Okay. Pharyngitis and tonsillitis, again, the most common cause here are again viruses, and that's why we don't indiscriminately give antibiotics to patients with the tonsillitis and pharyngitis. The symptoms here, you have features of acute inflammation, so the inflammation, the redness, the swelling, then maybe you can have an exudate. Sometimes you can have a membrane. This is the pseudomembrane. You get pseudomembranes with some bacteria. And the most common cause of pharyngitis and tonsillitis are influenza viruses, parainfluenza viruses, Coxsackie, rhinovirus, coronavirus, Epstein-Barr virus, and adenovirus. So again, mainly the viruses that gives you pharyngitis and tonsillitis. Okay, for the bacteria, strep pyogenes, and remember we have talked about possible complications of the strep. Okay. Mainly group A, but you can even have group C and G also giving you the same problem. You can have corynebacteria, the diphtheria and the ulcerans, and even mycoplasma pneumonia can give you pharyngitis and tonsillitis. Okay. For the laryngitis, again mainly viruses. The viruses, influenza, parainfluenza, rhinoviruses, adenoviruses, coronavirus, metapneumovirus, and then now we have a few bacteria like strep pyogenes and corynebacterium diphtheria, and even Epstein virus can also still give you laryngitis. So at this point, the upper respiratory tract infections will be dominated by viruses. You get hoarseness of voice. The voice becomes either lower or deepening. Basically, just some voice changes. Then this tends to be unlikely to be life-threatening. Okay. Laryngotrachobronchitis, these are a bit serious, especially in children. Patients will present with stridor, they have hoarseness of voice, they have fever, and they have what we normally call barking cough, giving you the croup. Again, tends to be mainly from viruses, so parainfluenza virus, influenza virus, respiratory syncytial virus, and then the adenoviruses. But this can be serious because it can give you stridor. Glottitis, again, inflammation, edema, inflammation of the epiglottis and the soft tissue about the vocal cords are very common in children. So they'll have fever, difficulty in swallowing. They can also have that respiratory disorder. But again, this can be from viruses and also from Haemophilus influenza type B. That was upper respiratory tract infection, mainly viruses. Most of them are non-life threatening. A few of them caused by bacteria. Now, for the lower tract infections, we're mainly dealing with the pneumonias. The pneumonias here, the broad description of pneumonia is an infection of the lung parenchyma, or infection and consolidation of the lung parenchyma, not the bronchioles anymore, not the bronchi. Okay. And we normally classify them according to either the agent itself. So if we get Staphylococcus pneumonia, we'll say this is pneumococcal pneumonia. So this is a pneumonia caused by Haemophilus influenza type B. Or if this is viral pneumonia and you have cultured or you have detected the virus, we say this is a SARS-CoV-2 pneumonia. Or sometimes we classify them based on a clinical setting. A community, this is a patient who was in the hospital. This is an acute pneumonia. This is a chronic pneumonia. This is a pneumonia that has been acquired based on this patient who was admitted, or this patient has some treatment, so treatment related, nosocomial, or therapy related, or chronic, or acute, or this patient is immunosuppressed. So we say this is a pneumonia related to immunosuppression, the clinical setting. If we cannot detect a pathogen, and most of the cases it's very difficult to detect pathogen, viral, then we classify them according to the clinical setting in which they occur. So we have the community acquired means this pneumonia was acquired outside the hospital. We'll call it community acquired. Or this was acquired in the hospital. We'll say this is healthcare associated, or this is a nosocomial acquired pneumonia. Okay, and one type of pneumonia, like viral pneumonia, can predispose to another. And in fact, even if you look at some of the complications of viral pneumonias, it's normally predisposed to bacterial pneumonia. Okay? And this could be due to either systemic compromise or a specific pulmonary defense being compromised. So you can have both occurring viral and bacterial pneumonia, or one coming after the other. Although most of the pneumonias are acquired through droplet infection, this is the enterothelial respiratory tract, you can get hematogenous spread. You still call it pneumonia. Like if a patient has septicemia, then they get this bacteria into the lungs, yes, and there's infection of the lung parenchyma, this is still pneumonia. So most of the pneumonia is droplet infection, but sometimes you can have hematogenous spread. And one of the most common cause of mechanism of death in patients with terminal infections or terminal disorders is normally from pneumonia. So a patient has cancer, yes, or a patient has polytrauma, or a patient has had surgery for another related conditions. There are high chances that one of the things that's going to kill them is actually pneumonia. And you'll see the reason why. And you think, especially when they are hospitalized, the so-called nosocomial infection. And you'll see that nosocomial infection, I'm very sure you've been taught, nosocomial infection tends to be very difficult to treat because mostly you have infections with the very resistant organism. Yes, we have a combination of antibiotic resistance. You're dealing with an organism that has antibiotic resistance. You're dealing with a patient who have a lot of invasive procedures, and most of the time when you have invasive procedures or you have surgery, you tend to have some form of immunosuppression. Or you have equipment contamination, you have contaminated catheters, you have contaminated intravenous devices, and then you're pushing bacteria right into the bloodstream. Okay? And of course, you get more pneumonias, you get more bacteria, you get more resistant bacteria in the hospital because there are very many sick patients there. And there's like a larger collection of bacteria there that you get in the community. So even a patient with chronic kidney disease, yes, there are high chances that they'll get pneumonia somehow, especially if they're hospitalized. Okay? And what are the predisposing factors for the pneumonias? Most of the pneumonia, what is the predisposing factors? Patient with the decreased cough reflex leading to aspiration. So patients with in coma, patient post-anesthesia, patient with neuromuscular disorders. Or when you have injury to the mucociliary apparatus, you injure the cilia, like in cigarette smoking, like in viral infection. It's now why viral infection predisposes to bacterial infection, genetic defects, including cystic fibrosis and the Cartagena syndrome. Secretion accumulation, what you see with cystic fibrosis, and also with chronic bronchitis. Chronic bronchitis is not an infectious disease. And please don't include chronic bronchitis as a pulmonary infection. Acute bronchitis is, infection. Chronic bronchitis has a slightly different pathogenesis, but it can be exacerbated by a pulmonary infection. Your patient has some decreased phagocytic or bactericidal function of the alveolar macrophages. Best example again, tobacco smoke or oxygen toxicity. If you give children high pressure oxygen, high pressure, high concentrated oxygen. Yes, hyperbaric oxygen therapy. This can predispose to pneumonia. Okay. A patient who is just immunosuppressed, either the innate or the humoral or the cell-mediated immunity. Of course, this one will be, and we see this very well in patients who have AIDS. With that, a defect in the cell-mediated immunity. They also will predispose to pneumonia. A patient who has congestive heart failure, one of those valvular diseases, giving you congestion or edema, or this actually pulmonary edema, can also predispose to infections. You're basically producing a culture medium in the lungs. So these are the risk factors. The risk factors for pulmonary infection. So we look at what we are calling pneumonia syndrome. Pneumonia syndrome is we're trying to classify the pneumonias based on the organism, based on the chronicity, based on the clinical setting, and based on the etiology. So here, that's what we mean by pneumonia syndrome. So we'll have community-acquired pneumonias. Then we'll have hospital-acquired pneumonias. Then we have chronic pneumonias. Then you have pneumonias in an immunosuppression state, opportunistic pneumonias. So community-acquired means these are patients who are not hospitalized. These are patients who these infections are occurring outside the hospital setting. We'll call them community-acquired. And the best example of community-acquired pneumonia is the strep pneumo. You can also have Haemophilus influenza from A to F, but typically B. You can have Moraxella catarrhalis. This nomenclature may have changed. So if I'm mentioning an older nomenclature for bacteria, use the one that you're given during the microbiology. Okay, Staph aureus can also occur. Legionella pneumophila typically patients living in a crowded environment with poor air conditioning. Enterobacteriaceae, Klebsiella pneumonia, and Pseudomonas species. We get Klebsiella typically, this is very common in alcoholics. Mycoplasma pneumonia can also occur, community acquired. Chlamydias, pneumonia, stachy, and trachomatis. Coxiella can give you that, and even a whole host of other viruses, RSV, parainfluenza, metapneumovirus, influenza A and B, and even the adenoviruses. All these can give you a community acquired. Basically, you're saying this one is occurring outside the hospital setting. Best example is actually strep pneumo. Predisposing conditions for community acquired, extremities of age, chronic disease like COPD, immune deficiencies, a lack of spleen function, because we normally need the spleen to remove opsonized bacteria. And the best way of removing capsulated bacteria is by trying to opsonize them. So if you don't have spleen, then there are some bacteria that tends to be very predominant in patients without a spleen. Typically capsulated bacteria. And here we have two. We have strep pneumo, and then we have Haemophilus influenza. And then the other one is Neisseria meningitis. So patients who have had splenectomy or patients who have had these are sickle cell patients with autosplenectomy. You have to give them they normally have they don't have adequate splenic function, so you must give them vaccines or prophylactic antibiotics for capsulated bacteria. And to confirm that these actually are infectious conditions or inflammatory conditions, they normally have acute phase reactants being positive. Best example here being C-reactive protein and also procalcitonin. Of course, even ESR will be high. They have biomarkers of inflammatory changes. Okay. So this is a community-acquired pneumonia. We'll discuss the pathology because the pathology tends to be only divided into two categories. So we are dealing with them according to the clinical setting, occurring in the community or is occurring in the healthcare situation. Healthcare basically is saying this is there's recent hospitalization of more than 2 days. There's either this patient who lives in a long-term care facility, like for the old people's home, or there's a patient who goes to the hospital, is not admitted in the hospital, just goes to the hospital for hemodialysis or for some cleaning, or this patient has a recent intravenous therapy, or this patient has a recent chemotherapy, or this patient has a recent wound care, but they are not admitted. Normally, this one we call healthcare associated pneumonia, and we get it mainly with the Pseudomonas aeruginosa, very common, and then we have methicillin-resistant staph aureus. Because here, because you have given antibiotic, there's choosing of a resistant organism that now are going to remain, and this is the one that are going to give you problems. And this tends to be slightly resistant organisms. Wound care, you will find staph. Wound care gets to be infected by Pseudomonas aeruginosa. Patient not admitted, but patient is receiving some form of treatment. That will be healthcare-associated pneumonia. Nosocomial, patients in the hospital. Typically, patients in the hospital. So this is acquired during hospital stay, and there's a severe disease. This is a patient who is sick. Other diseases. This is a patient who's had multiple injuries. This is a patient with kidney failure. This is a patient with lives on actually on mechanical ventilation, like in ICU. So this is typically what you find in a high dependency units or critical care units, ICU and HDU. Patients normally stay there for a longer time, and they have severely ill patients. So again, here you get mainly gram-negative rods, the Enterobacteriaceae, so the Klebsiella, the Serratia, the E. coli, and of course the Pseudomonas. And the staph aureus we get here normally tends to be methicillin resistant. So these are patients who are admitted and they are sick and they have prolonged antibiotic therapy and they have invasive devices in them. They have indwelling catheters. These are patients who are on a mechanical ventilation. Basically, these are patients who are in a critical care units. Okay. Aspiration pneumonia, you get this from either this is a patient who aspirate. Aspiration is when you have a food particle or a gastric content being diverted to the respiratory tract. So the infections you get are from bacteria that are normally the oral flora of the mouth, admixed with even with other aerobic bacteria. So you get oral flora of the mouth, the Bacteroides is anaerobic, Prevotella, Fusobacterium, Peptostreptococcus, mixed with the aerobic bacteria, Strep pneumo, Staphylococcus aureus, H. influenza, and P. aeruginosa. But basically, you're saying when you see aspiration pneumonia and also when you see lung abscess, we are dealing with mixed infection. dealing with mixed infection. Normally, the best way just remember is a mixed infection. So these are patients who are markedly debilitated, patients who are very sick, or they are unconscious, so they cannot control their, cannot close their epiglottis. Okay. So if it is gastric content, there will be also be some form of chemical pneumonitis, but also we have a mixed oral flora, the ones we have mentioned here, giving you the pneumonia. And the pneumonia tends to be very severe, the pneumonia tends to be necrotizing and pursues a fulminant course. And that's the reason why before you are taken to theater, before you are given general anesthesia, you normally make sure that your stomach is almost empty. Because if you vomit, when you are unconscious, there are chances that this will be aspirated. And if this gets aspirated, it's a severe and fulminant pneumonia, and lung abscess normally is a common complication of aspiration pneumonia. That leads us to necrotizing pneumonias and lung abscess. You said one of the common causes is aspiration pneumonia, but you can also get necrotizing pneumonia and lung abscess from other pneumonias like staph aureus, Klebsiella pneumonia, Staphylococcus, and type 3 pneumococcus, other pneumococcus. But it's typically what you see with aspiration pneumonia. You get necrotizing pneumonia with a lung abscess. This is what we had said here. Okay, so for mixed pneumonia, mixed infection, anaerobic flora, and also other pneumonias. Okay. And what happens with the lung abscess? We say the etiology of lung abscess and necrotizing pneumonia is typically from aspiration of infected material or pharyngeal procedures, secondary diminished consciousness, or you can have a primary bacterial infection, another primary bacterial infection that now hematogenously spreads to the lungs, or you can have a pneumonia, other pneumonias, other bacterial pneumonias, okay, which is now organizing to be more severe, to be more fulminant, and also cause necrosis with the formation of pus, giving you the abscess. You can have an emboli from an infected thrombi or a right-side endocarditis. If you have endocarditis, then this can be necrosis infection of the endocardium and the valves of the heart, and this can spread to the lungs. When you can have an obstructive tumor, like a tumor on the lung, basically when you have a tumor, it means the fluid does not move. Like for instance, if this is the lung, sorry, that is the trachea, and this is the lung, and you have a tumor here. This tumor will compress the bronchiole. Let me just change the ink. Now, so if this is the tumor, so it's compressing on the bronchiole. So there is no return of this of the mucus. So the mucus remains somewhere there, accumulates here, accumulates there, cultures the bacteria, and the bacteria gives you a necrotizing inflammation when you end up with an abscess. Okay. Obstructive tumor, and also you can get direct traumatic puncture or infection, the spread of infection from adjacent organs. Yes, I hope we're still together. Sorry, I lost network. So we are talking about sorry, I'd lost network. But you're talking about necrotizing pneumonias and lung abscess. So these are the possible etiology of necrotizing pneumonias and lung abscess. Aspiration, a previous bacterial pneumonia that just becomes more severe, or an infected thrombi lodging in the lung and spreading the infection, or obstruction of the mucus flow, giving you culturing the bacteria that is there, and also direct trauma or punctures there from the adjacent organs or from procedures. The morphology normally you can have a single or multiple abscess, depending from very large to very large, from very small to large cavities. And of course, because they are an abscess, they have pus, and also because it's in the lung, they'll have air. And if it's a chronic abscess, you'll have a fibrous wall. So what you have is an abscess there, and then this is the wall, and then you have a central section here that is full of pus. It's an abscess. Okay. Now, an abscess complications can actually perforate and get in the pleural cavity to give you what's called empyema. It can cause hemorrhage when it erodes major blood vessels in the lung. It can also septum embolize, move from the lung to another site. It can give you secondary amyloidosis when it is chronic. Amyloidosis is just excessive production of beta-pleated protein that gets deposited in tissues. And because it gets depleted, it gets deposited in tissues. In tissues where that deposition occurs, you can have defects or deficits. We see this also with the chronic inflammations or chronic inflammatory conditions like rheumatoid arthritis. It's basically just a complication of chronic inflammation. This is an abscess, this is the lung, slightly hyperemic, but what you have here is the wall of the abscess. And the wall here. So this is another locule, it's one locule, it's another locule. But what you find here is connectosis, it's full of pus. This is an abscess. Lung abscess, from pneumonias, and typical also from aspiration. And they usually both anaerobes and aerobes. Chronic pneumonias, these are pneumonias that have a longer time period. We see them mainly with the either filamentous bacteria like nosocomial or actinomyces, or we see them with the tuberculous bacteria. Sorry, mycobacterium, and of course other typical mycobacterium. We also see them with a fungal infection, systemic fungal infection like histoplasma and blastocystis dermatitis. So many of these are systemic fungal infections. These are bacterial, mycobacterial infections. And the reaction they normally give you is a granulomatous inflammation. They can be localized in immunocompetent patients. They can actually disseminate in immunocompromised patients. Typical localized granulomatous inflammation in immunocompetent patients. Sometimes they can go to the lymph nodes. So that means they're normally well localized and well walled off in a patient who's immunocompetent. In a patient who is immunocompromised, they can be disseminated. And we have seen this even in the bone marrow. Yes, we have seen actinomyces going everywhere into the mouth in patients who are immunosuppressed. These are chronic pneumonias, longer onset. Okay. Typically gives you chronic granulomatous inflammation. Okay. In the immunocompromised host, you have a long list. Basically, this is what we call typically from opportunistic infection. So CMV and pneumocystis jirovecii, MAC, this is Mycobacterium avium intercellare complex, invasive aspergillosis, invasive candidiasis, and of course, when you ask about pneumonia in immunocompromised patient, you include all the other bacteria, all the other viruses, and all the other fungal organisms we have mentioned. They can still get those, but these are really specific to immunocompromised host. You rarely see CMV pneumonia in a patient who's immunocompetent. You don't see pneumocystis jirovecii in immunocompetent individual. And even MAC, this tends to be again not very common in a immunocompetent individual. Immunocompetent individual, you don't see as invasive aspergillosis. What you see is called aspergilloma. Okay. And the risk factors, pneumonia in immunocompromised host is very common. We see it in almost 30 to 40% of hospitalized HIV/AIDS patients. And the viral load, not the viral load, the CD4 count will determine which kind of infections you see. Less than 200, you get tuberculosis. 50 to 200, pneumocystis comes in. And very, very low levels of CD4, you get CMV and the MAC complex. This is Mycobacterium avium intercellare complex. And of course, you've said the common of the bacterial pathogens will also cause severe disease. So the staph pneumo, the Klebsiella pneumonia, all those will still give you pneumonia in immunocompromised host. And the malignancies, the Kaposis, the lymphoma, the lung cancer will also worsen or predispose to pneumonia in immunocompromised host. And we see this a lot in patients who are immunocompromised. Again, I said I'm not going into the details of each organism. I just want to show the whole picture of how bacterial pneumonias will typically appear, a whole picture of what you mean by a typical pneumonia. Basically viral pneumonia or non-bacterial or interstitial pneumonia. So when you lump them together and say bacterial pneumonia, and even when you ask a question about discussing bacterial pneumonia, now you limit yourself to bacterial pneumonia. Yes? And acute inflammation and consolidation or solidification of lung due to a bacterial agent, we'll call that bacterial pneumonia. Remember, now we are not going to the issue of community-acquired, hospital-acquired. We are limiting ourselves to the bacteria. And the pattern of the infection we are having, the anatomic pattern we are having. When you do the X-ray, what do we see? How will our patients present? What do you see in the lab? So the typical characteristics of clinical signs and symptoms of bacterial pneumonia will be fever and chills, systemic features of inflammation, productive cough, the yellow-green pus or rusty, or sometimes in a blood-stained sputum. They'll have tachypnea, this breathlessness. They'll have pleuritic chest pain when you have a pleural involvement. They have decreased breath sounds, rales, dullness, percussion. Basically, when you auscultate, you'll hear that they're breathing much softer, and you don't hear the breath sounds because there is consolidation in the alveoli. Okay, and the lab, generally they'll have increased WBC. This is leukocytosis. With the you do culture. When you culture, you'll culture something. You do culture of the sputum, or culture of the pioncaveal lavage, or you do culture of the blood, you'll get that particular organism. And of course, the acute phase proteins, ESR, procalcitonin, and CRP will be elevated. Okay. Now, chest X-ray normally some of the mainstay ways of investigating bacterial pneumonia. When you do chest X-ray, you tend to see mainly two patterns. One is called lobar or segmental consolidation. So when you see lobar or segmental consolidation, that's how we call it, lobar pneumonia. That on the term we use is lobar pneumonia. You see lobar pneumonia, then you worry about this kind of organism. If you see bronchopneumonia means it's a patchy opacification throughout both lobes and sometimes can be bilateral. Lobar means it's involving either one lobe or two lobes, and the other lobes and the other part of the lung is okay. Sometimes you can see pleural effusion because you can get pneumonic effusion. It's inflammation. Inflammation normally have a exudation of fluid. Okay? So depending on the bacterial virulence and the host resistance, the same organism can cause bronchopneumonia, the same organism can cause lobar pneumonia, and sometimes can cause something between them. So it's not always black and white. That strep pneumo will only give you lobar pneumonia. But if you see lobar pneumonia in an adult, then you think maybe this could be strep pneumo. If you see lobar pneumonia in a child, you're worried. That is not strep pneumo, that's something else. Children tend to have mainly bronchopneumonia. The lobar pneumonia in a child, you might be dealing with tuberculosis. So in a way, basically this is how it looks like. You can see this one here. The dark area is the normal air. Dark area is the normal air. You can see the consolidation, the whitish area, you are seeing it only on the upper lobe. This is lobar pneumonia. It is about a single lobe, it's unilateral. Interstitial pneumonia, you see them mainly, you don't see a full consolidation. You see them like they are running through some patches only, Bronchopneumonia, you see a consolidation, but it's all over. You can see here this on the lower side, going to the upper side, and also the other side is also involved. So both lobes are involved. So basically, this is a bronchopneumonia. Patchy bilateral disease is asymmetrical. This is interstitial space, interstitial pneumonia. This is lobar pneumonia, only one area involved. Lobar pneumonia. Okay. This is a lobar pneumonia. Only part of the lobe involved. The left lung is normal. You can see air, that dark area as air. Okay. This is interstitial pneumonia. You don't see complete opacification. The white areas are not normal. These are ribs, these are ribs, these are ribs. This is the heart. But you can see a reduction on that black area. Okay. So lobar pneumonia involves essentially an entire lobe or two lobes. It is mainly unilateral. Okay. And we see it typically with strep pneumo, very common with strep pneumo. And there are four stages of inflammatory response, or normally what we call four phases. Pathology books normally like this, and also the physicians will teach you this. There are normally four phases of lobar pneumonia. One is called congestion. Congestion is just basically due to increased vasodilation and increased edema. So active hyperemia and edema will give you congestion. And then hepatization means the lung starts looking like the liver because you have neutrophil exudation. On top of that, you have hemorrhage. The lung becomes red like the liver. That's normally what we call red hepatization. And then you degrade the red cells, you remain with fibrinous material. Now it becomes gray. It is the gray hepatization. And then once now the healing starts, there's resolution. That is healing. So congestion, red hepatization, gray hepatization, and then resolution. This will occur if you don't give antibiotics. If you don't give antibiotics, you don't get the full spectrum of the inflammatory response. So if your patient don't give antibiotics, this is how they'll go. Okay. And in microscopy, morphologic features, microscopic features, or histomorphologic features, you see alveolar inflammation. You see neutrophils, because this acute inflammation, you see neutrophils in the alveolar, so intraalveolar secretive inflammation, and edema, features of acute inflammation. And it's mainly involving the alveolar. Yes, that's typically what you see the bacterial pneumonia of the lobar pneumonia variant. Now, bronchopneumonia, you have scattered patchy consolidation centered around bronchioles, tends to be bilateral or multilobar or basilar. It affects the young, the old, and the terminally ill. And when you said in children, you see mainly bronchopneumonia. And the organisms, Staphylococcus, Streptococcus, Haemophilus, Pseudomonas, etc. And the microscopy again, you see acute inflammation around the bronchioles and even in the alveoli. Still acute inflammation. Okay? It's just the pattern how this is done that's different. We say this is a bronchopneumonia. It's both sides involved. Lobar pneumonia, only one lobe or a part of it being involved. Okay? Yes, this is a growth fault. Let me start with the normal lung. This is the normal lung. It's slightly dematous, but otherwise normal. Then you can see this one is different. This is gray. This is more congested. This is the gray hepatization. This is the gray hepatization. And you can see it's involving only one lobe. The other lobe is normal. This is gray. So this is gray hepatization of the lobar pneumonia. But if you look at this, you don't see the demarcation between the lobes. So there's a consolidation here, there's another one here, there's another one here. In between, there are normal lung tissue. So this will be bronchopneumonia. This could be a lobe. This could be the demarcation of a lobe. And you can see it's involving both sides of the lobe. In fact, the whole lung is involved. This is typical of bronchopneumonia. So this is bronchopneumonia. This is lobar pneumonia. And this gray, this is the gray hepatization. Yes, bronchopneumonia, consolidations are all over. This one, the consolidation is only on one lobe. This is lobar pneumonia. Again, the same thing. Very clear gray hepatization now. You can see it very well delineated from the normal lung. But even here, there's some mixture. But typically, this is the gray hepatization of the lobar pneumonia. This is a pneumonia. You can see it has crossed the lobe. The patches of consolidation are on both sides. This is a bronchopneumonia. And it's the same picture you will see on the X-ray. And you look at it under the microscope, you see this is the alveolar. And the alveolar is full of cells, and they are mainly neutrophils. Alveolar is full of neutrophils. The interstitial pneumonitis that we are going to see next, the alveolar is almost empty. So the alveolar is not affected. The alveolar is not affected. The alveolar is not affected. It's in the interstitium. In between the alveolar, you see mainly lymphocytes. This is typically what we see with the viral pneumonia or atypical pneumonia. And we need to make that distinction, because if you think this patient has atypical pneumonia is two things. Either it's viral or it's an unusual bacteria. If it's an unusual bacteria, you make sure you give your patient empirical antibiotics that's going to cover both gram-negative and gram-positive. You are the experts in the drugs for gram-positive and gram-negative. And you have to know, because we'll be calling you while you are in the pharmacy. I have a patient who I think has a typical pneumonia. What do you have for me in the store? Okay. So, histomorphologically, you see for bacterial pneumonias, you see neutrophils in the alveolar spaces. And for the viral infection or the typical pneumonias or the interstitial pneumonitis, you see mainly lymphocytes. Remember we said last year that viruses typically don't give you acute inflammation. Viruses tend to give you a chronic inflammatory infiltrate form. They give you mainly lymphocytes. So this still follows even up to here. Bacterial pneumonias, how you diagnose? Sputum, you can do gram stain of the sputum, you can do culture of the sputum, you can do bronchial alveolar lavage, you can do bronchial washing, yes, you can do blood cultures, you can do PCR, yes, you can do fungal cultures, you can do special stains, you can even do other things if you are talking about non-bacterial. But for bacterial, gram stain and culture or blood culture. After the complications of bacterial pneumonia, you can give scarring, basically chronic inflammation. Scarring, pleural effusion, this is chronic inflammation. Fibrosing inflammation. You can give an abscess. Remember we talked about abscess coming from bacterial pneumonia. You can get empyema. Empyema is when you have pus in the thorax, in the pleural cavity. Pus in the pleural cavity, we call it empyema thoracis. Empyema thoracis. You can have sepsis. This inflammation spreading. Sorry, I have repeated lung abscess. This inflammation spreading to the rest of the body. So these are possible complications of bacterial pneumonia. Now, a typical pneumonia here is not per se just viral, but they're mainly viral. This is when you have a pneumonia without consolidation. You have some form of pneumonitis, but it's mainly in the interstitium. This is showing it better. This one here, you can see this is the alveolar. This is another alveolar. And the alveolar is empty. Most of this inflammation is occurring between the alveolar. Between the alveolar is the interstitium. We have an interstitial pneumonitis. And that's what's going to give, because the patient has features of pneumonia. All those we mentioned, they have fever, they have tachypnea, they are coughing, they have sputum, sometimes it's rusty. You're giving them oxygen, but it doesn't seem to be working. Yes? But if you look at the X-ray, you don't see the typical consolidation. Let me also wrap this. You can see here there's a consolidation. There's a white patch that is completely filled. Same thing here. You come here, you can see an area that has completely been, this is what we call a consolidation. But the interstitial, you're seeing just patches. Okay? It's like these are not completely covering the alveolar. This is interstitial pneumonia. You see, typically what the clinicians will refer as, and the clinicians includes you. The term for you could be, the best would be atypical pneumonia. And they can be caused by usually viruses, but also very few bacteria can do that. The best being Mycoplasma pneumonia, but the rest you can see are mainly just viruses. It's influenza viruses, parainfluenza, RSV, adenovirus, CMV, varicella, and so many others. What you get is a typical pneumonia. They are more common in children and young adults. X-ray shows diffuse interstitial infiltrates. Microscope, you have a lymphoplasmatic inflammation within the alveolar septum and not inside the alveolar. Okay. Complications that, because they are viral infections, you can have a superimposed bacterial infection. We talked about that. But viral pneumonias can be prequel to bacterial pneumonias. Sometimes you can get what's called the Reye syndrome, when you have a viral illness and then you give patient aspirin, and that's why aspirin is normally not indicated for children, for fever in children. You can get this complication called Reye syndrome with swelling of the brain, some form of encephalitis, and also hepatitis. Atypical pneumonia, because they are viral, extremely varied, from just some chest cold, some coughing, running nose, to difficulty in breathing, to tachypnea, to just non-specific, non-localized systemic signs like myalgia and some fevers. But sometimes, like what was causing death in SARS-CoV-2 was what we refer to as diffuse alveolar damage, or ARDS. They can have extreme edema and exudation and damage to the respiratory membrane, giving you what we call diffuse alveolar damage. And these are patients who you ventilate with oxygen, but their oxygen levels don't improve. They have developed what we call respiratory failure. But most of these viral illnesses are mild and they're spontaneous. They are worse in patients who are immunocompromised, or they are worse in patients with additional underlying illnesses. Yes, this is alveolar inflammation. This is what we get with the bacterial pneumonias. This is interstitial inflammation. You see the alveolar is very okay. The inflammation is occurring outside the alveolar in the interstitium, not the alveolar. This is a interstitial pneumonitis or viral pneumonias. Bronchitis, inflammation of the bronchus. This is acute bronchitis. It could be virus, it could be infections like Bordetella. So the fever, the cough, the sputum production, or sometimes they can give you flu-like signs. This is acute bronchitis. Don't confuse it with chronic bronchitis. Okay. Bacterial agents and viral agents for bronchitis. Okay. Bronchiolitis, inflammation of the smaller airways, the bronchioles, typically in young children, less than 2 years, viral infections, acute onset of wheeze, dyspnea, cough, rhinorrhea. They can have respiratory distress. Rhinorrhea is just excessive mucus drainage, and we see it mainly with respiratory syncytial virus, RSV. So this again is a viral infection. RSV, parainfluenza, rhinoviruses, influenza viruses, adenoviruses, enteroviruses, and human metapneumovirus. So it tends again to be mainly viral infection of very, very, very young children. Tuberculosis, I'm very sure you have had a full discussion on Mycobacterium tuberculosis. So pulmonary tuberculosis, this is a form of a chronic pneumonia. Transmitted through inhalation of infected droplets. There are two forms. I'm very sure you are taught this. Primary, I'm very sure everybody, one of you has a primary tuberculosis somewhere. You get this infection when you're very young. But because your immune system is okay, they get walled off. So you just get a single granuloma, what you call a gone focus. Please remember the terms. Gone focus is the single granuloma within the parenchyma or extrapleural. We call it a gone focus. Yes. And also involvement of the hilar lymph nodes. When it involves the hilar lymph node, the term we use is a gone complex. And primary tuberculosis most of the time does not progress. They get walled off by the cell-mediated immunity. The part of the necrosis becomes calcified, and they stay there. You live with it for a very, very long time. But a few patients have a primary progressive primary pneumonia. They have tuberculosis that proceeds in the initial setting. Or sometimes when they are very, very unlucky, they may have what we call miliary dissemination, when this primary tuberculosis proceeds and spreads the rest of the body via bloodstream. The primary tuberculosis, pulmonary tuberculosis, is what you get when you are young. And the immune system deals with it by walling it off, and it's kept somewhere in the lung there and it stays. It does not progress. A few patients will progress. Sometimes a very unlucky patient, it might spread to the rest of the body. Otherwise, it's localized, it's walled off. Now, woe unto you if you get a defect in cell-mediated immunity. If you get a defect in cell-mediated immunity, then what you have is a reactivation. You have a previously well-kept, well-walled off, well-guarded primary pulmonary tuberculosis that now gets out of the barrier and now disseminates. So the secondary pulmonary tuberculosis, it tends to be mainly the reactivation in a previously sensitive individual. And from now here, you get a lot of pathology. The pathogen here is basically a granulomatous inflammation. If anybody asks you the pathogenesis of how tuberculosis causes damage, it's typically from a pulmonary, mainly from a granulomatous reaction. And the secondary tuberculosis now will give you all the severe effects, all the bad pathology that you're going to see in a tuberculosis, the cavitations, the fibrosis, the necrosis, the caseous necrosis. It can give you bronchopneumonia. We're going to talk about bronchopneumonia. It can give you a miliary TB. Miliary TB means that this can spread to the extrapulmonary site. It can go to the meninges. It can go to the nodes. It can go to the visceral organs, the liver, the spleen, the intestine. It can go to the spine to give you post disease. It can go to the fallopian tubes. It can even go to the epididymis. This is a reactivation. How do you diagnose it? This is how we normally look at the histology. Histology, you see what's called caseating or necrotizing granulomas. And we had last year, we discussed how a granuloma looks like. If you don't remember, a granuloma, the necrotizing one, has a central area of necrosis. It has activated macrophages. Some of them are multinucleated. Then it has lymphocytes. This is a caseating granuloma. The other granulomatous lesion that doesn't have caseation. Then, this is a Ziel-Nielsen stain. This is what we normally call Zeden stain. Ziel-Nielsen stain, you see what's called fast bacilli, acid alcohol fast bacilli. Because these patients have, these organisms have a thick layer of mycolic acid. They retain carboxyphosphine, the red part. They retain carboxyphosphine even if you decolorize it with that and alcohol. And they appear as red bacilli, slightly tinged with bleeding. So this is a positive Ziel-Nielsen stain or acid fast stain. Okay. These are the involved nodes. If you remember, we talked about the nodes being calcified. This is the lung lesion. So this is the gone focus. And together they are called, these lesions, they are called gone complex. You can see this in histology. You can even see this on X-rays. Yes, these are cavitations. These are normal. What looks like, what could pass as a slightly normal lung? This one here. But even here, you can see consolidation, consolidation, consolidation. So you have a bronchopneumonia picture. But on top of that, you are seeing cavitations. You are seeing a large cavities being formed. This is an extensive, large cavity. So these are what we call cavitating lesions, cavitating necrosis, fibrocaseous and cavitary fibrocaseous lesions. Yes, what we see here in TB. Okay. This is miliary TB. You can see innumerable nodules full of granulomas. This is a spleen. This is miliary tuberculosis. It tends to be disseminated. In short, this is the natural history and the spectrum of tuberculosis. From anatomical point, anatomical pathology, this is how we see it. The microbiologists might see it differently. The virologists might see it differently. But this is how we see it from systemic pathology or anatomic pathology. Yes, you get a primary infection that tends to be localized. Primary complex localized cassation, so cassation in the lymph node, cassation in the parenchyma. There's a healed, it tends to be healed, or lesion, or organisms not viable. So they are removed, they are walled off by the good active cell-mediated immunity. So it heals the scar, heals the scar. We can see this on X-rays. But a few of them becomes problem. A few of them progress. So we have a primary, progressive, primary TB. TB can have a hematogenous spread, goes to the liver, goes to the spleen. This is a miliary tuberculosis. Or you can have this proceeding directly into the secondary form. But most of the time, this latent lesion is the one that becomes reactivated. When your cell-mediated immunity drops, it gets reactivated. Or you can have a reinfection when you're older. So you get a secondary tuberculosis. A secondary tuberculosis now tends not to be well healed because these are now patients with a defect in cell-mediated immunity. And the main arm of the immune system that deals with intracellular bacteria, especially tuberculosis or tubercle, is normally cell-mediated immunity. CD4 cell are in conjunction with the macrophages. So most of this, the TB that you know, most of the patients you're going to see is most likely from secondary tuberculosis, a reactivation of a previously dormant lesion. Okay, and this can now progress, to give you progressive secondary TB. This can have a massive hematogenous dissemination to give you miliary TB, or this can have a localized caseating destructive lesion, either pulmonary or extrapulmonary, like this cavity and like the scar, like the caseation, or you can even also have caseation in the liver. This is the natural history and the spectrum of opportunistic infections. Your immune system is dead, so you have even opportunistic organisms causing infection. Unusual organisms, Pneumocystis jirovecii, aspergillus, especially invasive aspergillus, and CMV. And this is what we see with AIDS, we see with cancer, we see in patients who have a transplant. This is pneumocystis. Not going there. This is a mycology or a protozoology. This is fungus. This is aspergillus. You can have cytomegaloviruses. Cyto because it's a cell. Mega because it's a large cell due to a virus. And a virus is giving you a large odd-like inclusion in the cell. So you say the cell is enlarged and the cell is large. And you can still see, or take it from me, this is the lung, this is the alveolar. So this is a CMV pneumonia. For laboratory diagnosis, upper respiratory tract infections, we rarely bother with trying to get the diagnosis of that. But if you have to, you can get a throat swab, you can get nasopharyngeal aspirate. For lower respiratory tract infection, we can get sputum. If somebody's not having sputum, we can induce sputum. We can have tracheal aspirate. We can have bronchoalveolar lavage. Again, this is microbiology. This is for you to read. This is still microbiology. That is for your reading, still microbiology. We have finished the anatomic part. This is the current COVID status as per 26 October 2025. And this is the cumulative totals of deaths related to COVID. I'm not discussing COVID. COVID is virology. To me, COVID will just appear as viral pneumonitis, and in most of the patients, it will be asymptomatic. In a few patients, it will give you very mild symptoms, the fever, the running nose, the nasal blockage, and some patients will give you severe infection with the acute respiratory distress syndrome or some viral pneumonitis. And I am done. Any question?
Yes, I have a question.
Yes.
In cases where you are not you the only tool you have is a stethoscope, are you able to differentiate the bronchopneumonia, interstitial pneumonia, and the lobar pneumonia using auscultation, doing auscultation?
Yes, you can. For the lobar pneumonia, you will see a decreased breath sound and also the dullness to percussion on only one side or one part of the lung. Then you know only one part of the lung or one lobe is affected. But for the bronchopneumonia, you see this decreased breath sounds and dullness to percussion in both sides of the lobe or in almost all bilateral sides or multiple lobes asymmetrically. So you basically go with the symmetry. How many lobes? Because the way you normally look for should be lobar, or am I hearing them asymmetrically, both sides of the lung, up and lower, then I'll know I'm dealing with bronchopneumonia.
Thank you. Thank you.
Oh, good. It's very important you make that distinction because some people have said lobar pneumonia, adult, most likely strep pneumonia. Most likely you're dealing with a common bacteria. You see this a typical picture, bronchopneumonia in adult, you'll be worried. You're dealing with something else. A lobar pneumonia in a child, you might not be dealing with that bacterial infection. Maybe you're dealing with something else. You might be dealing with even something like tuberculosis. So that distinction in a center that you cannot do very many investigations is very important. But X-rays can actually easily show you those two characteristics. Any other question as I talk to Faith? Faith, I'm going to add the previous examination questions for this topic before I send it to you. I'll most likely do that on Wednesday.
Excuse me, Doc.
Yes.
Can you I've witnessed kids who suffer from miliary tuberculosis, especially when it affects the brain. They develop, they become autistic, or some become epileptic. Are you able to explain how this comes about?
Oh, the miliary. Remember we said for miliary disease, it means a disease that has spread. And yes, as you have said, it has spread even to the brain. The autistic is not the correct term. Autism is slightly different. Say maybe they get some mental retardation, slight mental retardation, or changes in mental capacity, or they become epileptic. This is just because of the scarring. Because in miliary tuberculosis, you are dealing with an excessive number of the bacilli. The bacilli just normally just too much. Like you can see, each of these is packed with bacilli. So if this one heals, the kind of the healing that you're going to have here is most likely healing by fibrosis, healing by scarring, not healing by regeneration. And remember, in the brain being a permanent cell, those ones don't heal by regeneration, they heal by scarring. So anytime now you're going to replace a normal neuron with a scar tissue, you'll end up with the epileptic changes, especially epileptic fits. And it's also the same thing with how why we sometimes give steroids if we suspect a child has bacterial meningitis, so that we try to reduce the amount of inflammation, the amount of healing with scarring that you can see again with the bacterial meningitis, which can also give you the changes that you have talked about, including the epilepsy, including the auditory deficits. It just boils down to the extensive healing with scarring.
Thank you. Thank you. Well understood.
Faith, is that okay? Okay. Thank you very much. I hope the next time we meet, it will be physical. Okay.